me great pleasure with my co-moderator to chair this session and to welcome all of you, and kindly take your seats as soon as you can because we are already 10 minutes late and we'll need to be very strict with time. So I would like to invite the first speaker, pharmacist Batool Jaffer Suleiman from the Sultanate of Oman. She's the director of the rational use of the director of the Directorate of the Rational Use of Medicine in Oman, which is probably one of the oldest departments. She's not one of the oldest persons, but the oldest departments in this field. So, Pharmacist Batool, please.
Thank you very much, Your Excellency. Good afternoon, ladies and gentlemen. It's a pleasure for me to be today with you. And first of all, I would like to extend my sincere thanks and gratitude to the organizing committee for giving me this opportunity to showcase the Oman's experience in promoting rational use of medicine. Well, this is Oman. It's a beautiful country. It is surrounded by Saudi Arabia, Yemen, United Arab Emirates, and Arabian Sea, and you can see it is a really beautiful country. It has an area of about 300,000 square kilometers and population of about 3 million. 2/3 of them are Omanis. The beauty of the health system in Oman that Omanis enjoy a very high standard, free medical care. Not only Omanis, also all government employees as well as some other categories. This factor, together with escalating costs of medicine, as well as other factors, which I'm going to elaborate through my presentation, led to the concern about possible misuse of medicines. And that's why in the year 1996, Ministry of Health requested WHO to evaluate the use of medicine in Oman. And although that was a short-term consultancy for about 1 week, and it was on small study, but the consultancy recommended that a team to be established in the Ministry of Health to monitor use of medicines. However, the Minister of Health take further action and instead of just establishing a team within the only pharmaceutical body which we had that time at Ministry of Health, created independent Directorate of Rational Use of Medicine, which is reporting directly to the Undersecretary of Health Affairs. This slide shows you the organogram of the pharmaceutical sector in Oman. We have 3 bodies, actually. 2 of them, they are reporting to the Undersecretary for Health Affairs, that is the Directorate General of Pharmaceutical Affairs and Drug Control. Their main job is registration of pharmaceutical companies and their products, quality control, laboratory, and licensing of pharmacists, assistant pharmacists, and pharmaceutical premises. The other Directorate General which we have is the Directorate General of Medical Supplies. This is reporting to the Undersecretary of Administrative Affairs, and they are responsible for the procurement, storage, and distribution of pharmaceutical products. We are reporting to the Undersecretary for Health Affairs, and we can be considered as independent. We not belong to any of other Directorate Generals. Well, my department has 3 main or 3 core functions. It's training, research, and publications. And there are a lot of examples for that one. And each year we are conducting about 2 to 3 workshops for GPs, each time for about 50 GPs. And also we are for the rational prescribing of medicine. Also, we are conducting workshop for the interns immediately after their graduation from the College of Medicine. So they will be ready before joining the work at the ministry's institution. There are also workshops for the pharmacist and assistant pharmacist in good pharmacy practice, as well as teaching them the proper methodology, how to measure use the drug utilization indicators to measure the performance of these health institutions. Also, there are other workshops for the nurses, because in some remote area, their nurses, they are taking the process of prescribing and dispensing of medicines. So that's why there are also workshops for these nurses in good practice of whether prescribing or dispensing. Public education campaigns. The public education is very, very important. And I have in my department, I have separate section which they are taking care of this issue. And recently, in January this year, we launched our national public campaign at the level of all Sultanate of Oman with a lot of activities. And we were targeting people everywhere, in the parks, in shopping malls, home visits, you name it. We are also conducting baseline studies, because if you want to decide to take any action or to introduce any intervention, you should know what is the magnitude of your problem. Is it worth or not? And then also you have to give priority, which is more important to do first. Intervention studies we are doing, and we are also monitoring drug problems. Many new drugs are available in the market, but I have seen many of the physicians, they are just prescribing medication without taking care of the side effect, drug-drug interactions, what type of test to be done before initiation of the therapy or during the therapy. And there is a poster about this one, it's outside. If you have time, please visit that one. We are also doing clinical audits, and we have successfully, we published 2 editions of Oman National Formulary. The first one was in 2003, and the other one is in 2009. We are also publishing a lot of therapeutic guidelines. Here we are in the middle between the prescribers, pharmacist, and patient. And no one is more important than the other for us. They are equally important. Now, this slide shows you what was the situation before the establishment of the Directorate of Rational Use of Medicine. In 2000, 81% of our physicians were expatriates. And they came from different countries with different backgrounds and training, and they have a lot of impact on the prescribing process. No GPs were trained in rational use of medicine. I remember first time when we conducted the first workshop of the GPs, everybody was thinking that this directorate has been created in Oman to cut the budget which is allocated for medicine. But nowadays, everybody knows that rational use of medicine is only to save the health of the nation, and as a consequence of that one, you will save a lot of money also. There were no induction exams for GPs. Now we are part of the examination team for the GPs. And any GP apply to work in Oman, whether on the private sector or public sector, we are part from the examination team. Of course, there are a lot of problems regarding with the public, regarding the language, the attitudes. And the WHO team that came in 1996, they measure some indicators, drug utilization indicators, and you can see the average number of drugs per prescription was 4.5, and the percentage of prescriptions with antibiotics was 60%. How was the situation of the pharmacist and assistant pharmacist? 72% of the pharmacists, 49% of assistants were expatriate. And there were no clear job description for them. Mainly they were underutilized, and they have very weak management skills. No clinical pharmacist, but now Ministry of Health, every year sending 4 pharmacists to get their training in Europe or the USA, Australia, and our target is to keep 1 clinical pharmacist for each 50 beds. Public, of course, everything is free, so you expect there is high demand and there is irrational use. Many of during the CAB study, which we have conducted, many of them, they say that they are visiting more than one health institution per day after a few hours. They want quick relief of the problem they have. There is, of course, different levels of literacy and strong traditional beliefs. And even the registration system in the country was not so well organized that the patient has easy access to visit more than one health center in the area. Yes, we have done a lot of job. I don't know, some of your results can easily be measured, but some of them you feel it, and we are feeling that we got some success in this area. Now, rational use of medicine is part of the 5-year health plan. So it is incorporated within the system of Ministry of Health. It is not like I will do it today, but not tomorrow. It is continuous monitoring of everything. Now, 34% of the pharmacists and 37% of the assistant pharmacists are only now expatriates. All of others are Omanis. The average number of drugs per prescription, as I have stated before, it was 4.5. Nowadays, in some of the regions, it is 2.9%, and this is the latest data of 2010. And we were able to train 32% of all the GPs which are working within Ministry of Health in issues related to rational use of medicine, and then prescriptions which contain antibiotic came down to 37% in one of the areas which we don't have easy access to them. It's a bit away from the capital area, while in the capital it is only 1.8. Well, okay. We were, as I have stated, the Oman National Formulary. We have the first and the second edition. Also, we published Formulary for nurses. There is a list of medication that the nurses can prescribe and dispense to the patient. But we thought that they should have some information, not just to give medication to the patient. And this formulary contains mechanism of action of this medication, as well as the possible side effect and the drug-drug interaction. So the nurses, usually they are aware of what they are prescribing for the patient. We conduct a small study. We visit the health centers, and there were about more than 25 pharmacotherapy guidelines. But we came to know that about 90% of the GPs, they are not aware of these guidelines. Why? Because the size was very big, a lot of information, and just one copy in each health center. So what we have decided, we took all these guidelines and we tried to combine them in a small booklet which can easily be fit in the pocket of the lab coat. And now every GP has this. So sometimes it's small intervention, but it leads to great effect. At the beginning, there were about 9 types of non-steroidal anti-inflammatory drugs in our institutions. Now we have hardly 2 or 3 of them. And also there were many drugs which were not evidence-based, so those were deleted. Also, we had some changes introduced, some changes in the curriculum of pharmacy. We have, which is under the umbrella of Ministry of Health, we have an institution for assistant pharmacists. And now the pharmacists, they have specific job description for the clinical pharmacist, ward pharmacist, and the pharmacists which are responsible for the management of the stores. We are also collaborating. We have currently we have 2 private colleges of pharmacy, and we have a college of medicine, one which is governmental, and the other one is private. So we are always cooperating with them. We have also our newsletter. It is called Pharmacological. Pharmacological is the logical use of medicine. Now, every GP has to be examined at the time of recruitment, And we are doing also the financial analysis for primary healthcare facilities, like the cost per prescription in each health center. And people now started to accept, they have more awareness about the term of rational use of medicine, and they are accepting our role. Also, we have news groups, and this is the website. If you have, we welcome everybody to share us in that one. What is my message to you? Well, it is very, very important, political will and the support. And you can see this is very clear, very obvious in Oman. His Excellency, our Minister of Health, is sharing us in this conference. And that is, I can't say more than this. Now, rational use of medicine is part of the program, and you can see the board for the name of Directorate of Rational Use of Medicine is incorporated. It is like within the other departments of Ministry of Health. And also multiple interventions is very important. Multi-component intervention is important. Single intervention is not come up with a good success. Please try to be a friend with everybody. Don't be a policeman. People will hate you and will never give you information. And you cannot work unless you have enough information from everybody, and their cooperation should be always. And thank you very much.
Thank you very much, Pharmacist Batool, and I'm pleased to say that actually Pharmacist Batool saved us 10 minutes for discussion. But now it gives me great pleasure to invite Dr. Jing from the Republic of China to talk about the experience in implementing the national medicine policy changes in China. And you have 25 minutes.
Okay, thank you, Chairman. Good afternoon. And firstly, I would like to thank the organizing committee of ESUM to invite me to attend this meeting and allow me to take this opportunity to share with you the experiences of China in the reform process, the progress made, and allow me to share with you my views on the challenges and the way forward in the whole process of the reform in the pharmaceutical sector. So my presentation will compose three major parts. And firstly, an introduction of the overall health system reform, the background. Secondly, how medicine sector reform as a part of the overall reform. And thirdly, in details of the essential medicine system as the foundation of the national medicine system policy, its content, its progress and achievements, and the challenges and the way forward. Firstly, the background. I think there are four key catalyzers for the national health system reform during the past several years. Firstly, there's a consensus of the high-level political leaders of developing a well-off society. And secondly, the fast economic growth allows the country, the government, to invest more on health, on public expenditure. And thirdly, there is no recognition of health as the foundation of human development, and by those high-level political leaders, and they have a very strong political willingness of coordinating this social and economic development with the health development. And fourthly, and there are some unsatisfactory of the people of access to health services in terms of both physically and financially. So here I will summarize the problems in the pharmaceutical sector before the reform in four key areas. Firstly, the availability of access of medicines. And there is a different scenario in the remote rural areas and the developed urban areas in terms of availability. In the remote rural areas, there is no access of basic medicines. But in the developed urban areas, there is a kind of alternative expensive medicines available there, but the essential medicines availability are low. And the second, affordability. And there is a continuously soaring health and medicines expenditure in China, especially during the past 10 years. And there's a high proportion of pharmaceuticals to health expenditure. And there's also a high proportion of out-of-pocket expenditure. In terms of quality, there is a public perception of local products with poor quality. And in the area of medicines use, the irrational prescription and unnecessary care has been intensified by the perverse incentives in the health system. And these are due to three major reasons. One is the distorted pricing system. And the pricing of generics has been set very low, and the originators has a very high level pricing. And the retrospective payment for service has exhausted the health resources. And the health facilities have to rely on costly medicines and diagnostic equipment and polypharmacy to compensate the weak government investment in the public sector. And there is the implementations of huge wastes of health resources and alarming burden of the drug resistance and adverse drug reactions events. And here I show you is the WHO High survey. It's a famous survey conducted globally. And the survey was conducted in China in 3 provinces, in Shandong in 2005, Shanghai in 2006, and the Hubei province in 2009. And there are several key common conclusions from these surveys. And one is the low availability of the basket surveyed medicines. And the second is the high price level of the originators in these 3 provinces. And these slides show you the total health expenditure and the total pharmaceutical expenditure in China between 1999 to 2010. You can see the soaring trend, and especially the very rapid growth trend, especially after 2005. And in China, 5% of GDP has been spent on health, and 45% of health expenditure are pharmaceuticals, are for pharmaceuticals. And there's only 27% of the total health expenditure are from the government. And the total government health expenditure only possess 6.18% of the total government budget. And there is 38% of the total health expenditure spent by the spent privately. And these slides show a study conducted by the South China Pharmaceutical Economic Research Institute in 2009. And among the 10 top market shared medicines in both anti-cancers, anti-lipemic, and there are more than 50% market share is for brand originator products imported or produced by the joint ventures in China. And according to the World Health Report 2010, and there was a study using data in 2008 and saying that if we switch from originators' brands to lowest priced generics in the Chinese public hospitals for limited basket medicines, and the total potential cost savings would be $86 million, and the average percentage of savings would be 65%. And there are also data from the Chinese National Health Service survey in 2008 showing the serious irrational use of medicines in terms of both antibiotics and infusions in both rural and urban China. And this high-level use of antibiotics and infusions show the irrational use of medicines so serious. And according to the report of the National Antimicrobial Resistant Monitoring Network report in 2006, the isolate rate of MRSA is over 60% in the clinical settings, and the incidence of highly microlide-resistant streptococcus is over 80%. So under such a background, the pharmaceutical sectors was reformed under the framework of the overall national health system reform. And in line with the reform, there is a government restructure. The Drug Regulatory Authority came back to the governance of the Ministry of Health, and the Ministry of Health established a new department responsible for the whole pharmaceutical policy issues. And so the National Medicines Policy Development Function shifted from the Regulatory Authority to this Ministry of Health department as well. And there's a high-level political commitment in the process of the health reform for a universal coverage of safe, efficient, convenient, affordable, essential healthcare system. And such a system composed four major components: for public health services, for medical services, and medical security, and essential medicines. So you can see essential medicines is one important part of the overall reform. And in the process of the reform, very high-level, state council-level health system reform leading group was established, and there was an essential medicine system office was established in the Ministry of Health as well, compromising 16 ministries for coordination and collaboration. And the development of the national medicines policy was resumed in the reform process. And I clearly remembered early in 2004, when the former director of the WHO Medicine Department, Dr. Hans Hogezil, you visited China, and you met the high-level officials there, and you organized technical seminars with the high-level officials. And following that, a serious technical support activities was carried out in China. But there were ups and downs of the development of national medicines policy. But in this round of the reform, such a process was resumed. And in 2008, a Healthy China 2020 research initiative was conducted, and covering each aspect of the national medicines policy. But unfortunately, such a document was not officially published, but not legitimately implemented following the research. And let's come to the essential medicines system in details. And such a system, the key objective of the system is to secure the accessibility, quality, and the rational use of medicines. And it's very much focused on the equity, sustainability, and the comprehensive reforms of the public primary care facilities. And in the whole process of the reform, selection of essential medicines has been regarded as the foundation for the implementation. It guided the supply, financing, reimbursement, quality assurance, and the rational use. And the so-called national essential medicine system is designated to make some changes in the following 7 ways. One is in the supply system. There should be established a pooled provincial procurement system. And for the pricing issues, and there should be price cut for those high price originators, and those two low price level generics should be resumed with an appropriate price level to compensate the basic production cost. And the same maximum retail and reimbursement price policy was under the generic name was issued for those medicines newly covered by insurance programs. For the financing issues, government committed to subsidize both the supply side and the demand side. In the demand side, essential medicines, all insurance programs are required to cover essential medicines. And in the supply side, policies of removement of markup on medicines should be issued. And the government subsidies to primary care facilities should be based on a comprehensive performance assessment system. As for the reimbursement policy, and there has been a requirement by the government to improve its benefit package, and the quality assurance should adopt an electronic coding system and conduct routine sampling and testing of essential medicines. In the medicine use area, the reform policy requires to adopt a health system approach to make improvement of medicines, to conduct the trainings as well as to consider the perverse incentives in the system and to remove those incentives in order to improve those medicines. And comprehensive reforms in public health primary care facilities are very much emphasized in the whole reform process. And the government required each province establishing a government procurement platform to do procurement. And the government subsidy should be based on the performance assessment instead of a directly subsidy to facilities. So there you can see there is a system construction in the process of the reform by coordinated actions by different ministries. So here I listed the 17 reform regulations after the major reform document was issued by the State Council. So each ministry, including health, financing, pricing, regulatory authority, social security, human resources, issued each individual regulations to cooperate with each other in the reform process of covering all aspects of the medicines. In the public primary care facilities, each facilities will be required to procure medicines via a provincial governmental procurement platform and contract directly with the manufacturers with committed quantities. A pooled payment via provincial government account is adopted, and with the purpose of giving a payment to the suppliers on time. And all provinces have already set up government procurement platform. 68% of the counties set up electronic system for doing procurement, and 26 provinces initiated a new round of procurement after the reform. As for the comprehensive reforms in the facilities, 25 provinces have set up a performance-based government subsidy mechanisms, and 24 provinces adjusted their diagnostic and treatment service fees, and various approaches has been adopted by different provinces to subsidize the village doctors, to secure a basic salary for them, allow them to charge fees covered by insurance, and expand the insurance programs to outpatient services, etc. In the reimbursement issues, 90 areas have already covered outpatient services, and the reimbursement rates of the rural health insurance and the urban resident insurance for inpatient services have already reached 60 to 70%. Insurance payment has been piloted in different provinces and areas to have the shipment from the retrospective payment to prospective payment. And in the quality area, regulatory authority have issued a revised GMP that is in line with the international standard and to be implemented by 2015. And in the intellectual property rights sector, a compulsory licensing provision was issued in 2005. A newly revised patent law was launched in 2008. And just in this year, the Ministry of Health started to explore a compulsory licensing process for HIV/AIDS medicines to have a sustainable financing mechanisms for the government. And although there have been a lot of progress and achievements made in the process of the reform, but you can see there are a lot of parallel government policies, reform policies issued. Although it covered all process, all aspects of the pharmaceutical sector, but it's yet an official and comprehensive food document published, implemented, covering all these aspects. And there is also a concern of the consistency of the government structures. Although there is a new department established under the Ministry of Health taking care of the whole pharmaceutical issues, but it's yet have enough time or capacity to consider the national medicines policy, but focused very much at this stage on the essential medicines only. And the essential medicines system, although it's already established and implemented at the national level, but such a system is not yet comprehensive to address some issues beyond this. For example, there's a lack of coordination mechanisms for all stakeholders, like a stronger role of the insurance programs in price setting, in doing the procurement, and the improvement of the rational use of medicines. And there is also a lack of mid and long-term national goal for the pharmaceutical sector. For example, how to develop a vial industry, a pharmaceutical industry for the country. And here I summarized the key challenges and share with you my views on the way forward in the following areas. One is the credibility and the acceptability of the selection of essential medicines process. And there need to be access to up-to-date and independent evidence to make informed decisions about the quality, safety, efficacy of the cost-effectiveness of medicines in the selection process. And at the lower level selection process, for example, at provincial level, evidence-based principles should be adopted as well, like at the central level. And there is also a need to guide on the dosage form and the strength of medicines, especially pediatric formulations at the central level. And there's also a need to coordinate between the insurance programs and the Department of Medicines of Ministry of Health doing the medicine selection. And in the financing area of the supply system, the government investment has been committed, but how to put this committed into action is still a question. And a performance evaluation-based government resource allocation has already been piloted and expanded, but need to be continuously implemented and strengthened. A stronger role of the health insurance program, a role of the payment method in changing the prescription behavior should be emphasized as well. In terms of affordabilities, there is also a very urgent need to conduct a pharmacoeconomic analysis of setting the price of new medicines. And in the development of, you can see, and you all know though, that there has been an increasing commitment of the government to subsidize the access to medicines by all the people. So the government has to spend more and more and invest more and more to secure this. And to save the government funding, there is an urgent need to develop and implement a comprehensive generic policy in China, and to strengthen the quality of generics, and to allow the pharmacists to substitute generics, and to conduct education to both professionals and the consumers on, to give them an appropriate perception on generics. And there is also an urgent need to create incentives for the prescribers, for the pharmacists, and for the consumers to use generics appropriately. And the other issue is the tax on essential medicines. Currently, the tax on essential medicines in China is up to 17%. Is much higher than the other countries. In terms of rational use of medicines, and it should be emphasized and strengthened and expand a health system approach to improve the medicines use. And the health insurance payment reform could be playing a more important role to create cost sensitive of the prescribers. And the quality of care supervision should be collaborated with the health insurance programs. And the public education should be conducted to build appropriate perception of medicines and medicines use. And the prescription behaviors should be should be covered as part of the performance evaluation of the health facilities, and linking this with their accreditation or others. Comprehensive interventions at all levels of the system should be conducted. Sorry. And in the quality assurance system, I think that the regulatory authorities should strengthen the inspection capacity and pay more attention to quality system rather than focusing very much on their hardware construction of the production facilities. And in terms of a supply system, there's a need to create incentive for public facilities to procure more essential medicines rather than others, and keep the transparency in the direct price negotiation in the process of procurement. And there is also a need for clear and objective quality standard based on the dynamic quality monitoring in the process of procurement. And in some provincial procurement system, there is also a tiered system for branded products and other subjective criteria existed in the procurement process. This should be adjusted. And there is also a need to strengthen the efficiency of the distribution management system. In terms of monitoring and evaluation of the reform and the health of the sector, of the pharmaceutical sector, monitoring and evaluation strategy and methodologies should be developed and as a guide for all levels of activity. And there should be also a regular data collection of price, availability, affordability, and use of medicines across the country. There is also a need for the government to allocate a government fund to support independent policy research in this sector. So I think this is the end of my introduction. Thank you very much for your attention.
Thank you very much. And now it gives me great pleasure to hand you over to my co-moderator, Dr. Suleiman to lead the discussion.
Hi, thank you very much. I'm quite honored to co-moderate this session. Well, in the morning plenary session, we learned from the international experiences of policies and programs. And this afternoon, we had two excellent presentations based on the experience of national systems, and specifically from Oman and China. Sorry. It seems to me that there are some differences in terms of approaches of these two countries. One, I mean, in Oman, is very much focused on the rational use of medicine, whereas in China, it seems very kind of a comprehensive approach. And so also it can be a kind of incremental reform versus a comprehensive reform. We should learn a lot from these two examples. First, can I ask Minister Ahmed Al-Said if he has some comments or questions for discussions for those two presenters, if you have any?
I think thanks to both presenters, they gave us plenty of time for discussion. One of the issues we faced in Oman, unfortunately the private sector growing, well, fortunately it's growing very fast, but unfortunately the regulations and the monitoring of the private sector is still very limited, and major misprescription or prescribing and misuse of drug at the moment coming from the private sector, which we do not have the ways and means to monitor. So I'm just going to ask Pharmacist Batool if there's anything in the pipeline that she can tell us about how to make it comprehensive, rational drug use, not only for the government sector, which is easier relatively to control than the private sector.
Thank you very much, Your Excellency. It's absolutely, you are, talking the right track, which we are thinking of. But, we have to do some amendment in the regulations of the private sector. Then we can start doing research in the private sector. Currently, the pharmacies, they are not keeping the prescriptions. The patient will come with the prescription. It is the medicine is given to him along with the prescription. So we cannot conduct any research to find out. Once we have done, we have asked the concerned department to just ask some of the pharmacies to keep prescription, and we received tons of this prescription within 3 months. And it was very difficult for us manually to analyze these prescriptions. Anyhow, the first impression was that there is very high percentage of prescriptions with antibiotic especially, and the other one was the non-steroidal anti-inflammatory drugs. So it is in the pipeline. Just we have to coordinate with the other regulatory body, that is the Directorate General of Pharmaceutical Affairs and Drug Control, to establish a system for keeping the prescription, either to introduce some software, electronic, so the prescription electronically could be saved within the pharmacy, or some other issue which is relevant, and we can then start conduction. Because as I have mentioned, we cannot do anything unless we find out what is the magnitude, what is the volume of the problem which we have. So it is in the pipeline, and we are going to do it. Thank you.
Thank you very much. And for Jing San, the expenditure on pharmaceutical is 44.5. You've mentioned some of the successes. I'll raise this point, and I would like you to tell us what is the plan to reduce the expenditure from 4.5. The other thing you've mentioned about generics, and as a clinical person, when I was practicing, unfortunately, I think the enemies of generic drugs are doctors more than patients. And it needs education of the prescribers before actually the public. We need them to have the confidence that these generic drugs are as effective as the original. You've mentioned the way you were trying to tackle this issue, but just if you summarize it, please. So first, the reduction in the pharmaceutical, and then the generic issue. Thanks.
For the questions in relating to the pharmaceutical expenditures, yes, it's quite high, and it's up to 44% of the overall health expenditures in China in 2009. And I think in this round of the overall health system reform, as well as the pharmaceutical sector reform, the government has realized this, and a lot of initiatives and policies has been issued and required to implement. For example, as I just mentioned, the Ministry of Health and other ministries, they collaborated with each other to issue a policy of removement of those markups on medicines, although this is a huge challenge for the Chinese public health facilities, because at least 15% of the markups has been added to the medicines in the public health facilities, and in some lower level primary health facilities, this markup rate is even much higher than this, and sometimes even up to 60 to 70% markup. So remove of such markup will be a big challenge in terms of financially to those public health facilities. And to deal with this, to in line with the removement of the markups, government have issued reform policies of conducting comprehensive reforms in those health facilities to increase the government subsidy to them, and to remove those markups, and to enable them to focusing on the treatment rather than making money from the markups. So removement of markup is one major initiative to deal with the high pharmaceutical expenditure. There are also some initiatives like the improvement of the insurance benefit package to increase government subsidy to patients, and to increase the access of medicines, etc. And to answer your question in regarding to the generics, yes, like I mentioned, and in China, it has a very big generic pharmaceutical industry, and 95% of the manufacturers are generic manufacturers. It's a generic country, but like I mentioned and introduced to you with some slides and the graphs and tables, you can see currently the Chinese people living especially in urban and developed areas, they are not using generics. They are using high-priced patented medicines or off-patent originators. But in the remote areas, people are not able to access to those generic medicines. And to implement such a generic policy in China, I think the first thing and the precondition, like I mentioned in my presentation, is to deal effectively with the quality issues of medicines. Like I mentioned, there is no public perception of people, and they think that the local products, generic products, are with lower quality, are not so effective as the branded products, as the originators. So this is the common perception, and how to make a concrete action by the regulatory authorities to improve the local generic products is really a challenge, and I think the regulatory authority has been on the way in making changes. For example, the newly revised GMP is a very comprehensive changes, and it's already in line with the international standards, and all manufacturers and has been required to comply with this. I think all those are the serious policies to deal with such an issue. Thank you.
Thank you very much.
I have one short specific question on China, and next question is for both presenters. First one is in your presentation, also in your just response to the minister's question, you mentioned the no margin policy on medicines. Well, in theory, it would be great if providers accept that policy and behave as we expected. But from an incentive perspective, I'm really concerned whether providers really accept this no margin. One possible behavior distortion of the providers could be they do not reveal the true information about the price, cost of purchasing medicines. So there might be more and more kind of issues, problems on the transparency of pricing information. So I'd like to have your really comments on that no margin policy, or if you have some preliminary results, empirical results about the impact of those no margin policy on the provider behavior. In the case of Korea, 10 years ago, Korean government introduced no margin policy. At the beginning of this year, in 10 years, finally government gave up and government declared it was a splendid failure. And now we have a kind of a market-based reimbursement policy such that providers are allowed to get some profit. Profit means the difference between purchasing price and the government reimbursement. So, from an economist perspective, there's no margin policy could create a lot of problems in terms of incentive compatibility of provider behavior. So that is a specific question to China. And I have common questions to countries. Well, we learned from the two success stories about pharmaceutical reform from Oman and China. But from a political economy perspective, pharmaceutical policy reform are involved with a lot of stakeholders, from the physicians, pharmacists, or industry, general public. So oftentimes, or very frequently, pharmaceutical policy reform is the area of a analysis of the political economy. So I'd like to learn from your experience or perspectives on what was the major barriers or challenges to the policy change, or who are the major vested interest groups or stakeholders, and how did you manage to overcome those oppositions from those stakeholders and vested interest groups? I'd like to, those experiences will give a lot of lessons to the audience in this room.
You have 2 minutes. This might take 2 days, but we'll give her. This might take 2 days, but we'll give her 2 minutes only. The first chat was specific to China.
Okay. In my presentation, I mentioned the government efforts in making the changes of the prescriber behaviors. And yes, like you mentioned, in many countries there has been a lot of efforts to make the changes and to affect the behavior of the prescribers. But I think the most important or effective tools for changing the behaviors of the prescribers is to use an insurance tool, an insurance program as a tool. For example, in some pilot studies, pilot areas in China, there has been a changing or exploration of changing the payment of the insurance. In primary, for example, in primary care, they changed the payment from fee-for-service to a capitation-based payment, and such changes give the cost sensitivity to the prescribers, and the prescribers will automatically consider the price of medicines, the cost of medicines, etc. So I think the insurance program could be an effective way in dealing with such behavior changes.
You can see that the rational use of medicine currently are focusing mainly on the public sector, our Ministry of Health, because more than almost 80% of the Omani population, they are getting their medical care through the institutions which is coming under the umbrella of Ministry of Health. Well, the system of approving the medication in the formulary is through committee which is chaired by the Undersecretary of Health Affairs, and the members of this committee, they are all consultants which they are working in the tertiary care hospitals, and therefore once any medication is approved, it is approved by all of them, so the decision is coming from the floor. It's not like an order from the office to the people. No, they are with us every time. This is one. And the other thing, that the procurement system in Oman, it is pooled and it is like centralized. Mainly the medication is through the centralized purchase system within all the 6 GCC countries. And therefore, this medication, once it is selected for Ministry of Health of Oman, it is available in all the GCC countries. Post-marketing surveillance is easy, and there is follow-up by the quality reports which are coming from different countries. So that's why, and even suppose this year they have taken from company X and they want to change next year for company Y, which is generic, it's not all the procurement, all the amount which is needed. It is just like on steps. First, they will take 30% from the new company. And this is the process of monitoring. And that's why, because people, there are, the decision is not a decision of a single person, it's a system. And that is the beauty that we have. Everybody is involved when we are deciding anything. That's why probably it is one of the factors that we are controlling. But I don't know what will be the situation when we will move to the private sector.
Thank you. Jing-san, do you have any comments to the political economic perspective or stakeholders' perspective? If you have, please do so, otherwise it's fine.
I think from my personal views, in the process of the reform of the pharmaceutical in China, and like I mentioned in my presentation, although there is a need, and is very clear to everybody that the Chinese government should adopt it in a very comprehensive generic policies in such a generic country and generic pharmaceutical industry, and up until now, the reform has been going on for 2 years, and there's no political discussions on this yet. Although we discussed this here as academics, and there has been a lot of recommendations or discussions, but this issue is yet being put on the agenda of the policy makers. I think in this process of the policy changes or reforms, and I guess there there has been a lot of conflict of interest between different stakeholders and the pharmaceutical industries, the consumers, the providers, the health professionals. Each stakeholders have their own private perspective on this towards this issue. So I think this is the major challenges or difficulties in the future reform process.
Thank you. Before closing, there is one question arrived from the floor, but this question is directed to His Excellency, the moderator. I'll just read. In your excellent speech in the plenary, you mentioned that the private sector is expanding. So can you explain how the private sector activities are being monitored?
Thank you very much. I'll make it very brief. We consider the private sector good partners in Oman, and we wish for them to grow and to participate and to add value to the healthcare in Oman. Unfortunately, up till now, the regulation, the policies related to the private sector are not up to the standard. Just recently, 2 weeks ago, we've appointed a Director General, and we raised the level from Department to Director General, the Minister of Health of private sector. We're increasing the capacity of that department. We are actually contracting the private sector soon as well to monitor private sector. There are companies which are specialized to monitor and regulate the private sector. The final say will be with us at the Ministry of Health, but they will be doing the day-to-day activity, inspection. We are limiting, in the past, you open a clinic and with it a pharmacy, and unfortunately there was lots of misuse of drug this way. The doctors working in the clinic, same sponsor having the pharmacy. We've stopped that practice already. We are allowing only pharmacies now in private sector hospitals, not the small clinics and polyclinics, and lots of regulation in the pipeline. It will take us some time, but if there are any people interested in having private sector practice in Oman, they are more than welcome because the need is there for those who can add value. But I can also assure everybody that the strict regulation to stop the misuse of medication and unfortunately high prices which are charged for things that should not be, and over investigations. These are all in the pipeline, and hopefully they'll be implemented soon. Thank you very much. Close.
Okay, thank you. It's time to close. So if you have further questions, you can just have a discussions with the presenters. Well, from my perspective, we have very clear lessons from those two countries. For example, the political will is so critical, important, and mainstreaming, as she said, mainstreaming the pharmaceutical policy is also another very important factors. And comprehensive reform in China is quite is remarkable. So, do you have any?
I just would like to thank you, the audience. You've been great, and you came on time, most of you. So thank you very much, and enjoy your next session. Thanks, both presenters, on behalf of you, and I wish you a pleasant day. Thank you. And thank you. Apparently, this is for you. Thanks. I think it's for you anyway.